Check. Check.
Hello everybody. Hello. We are starting with our next session. May I call upon stage Dr. Ravindra Kivalkar, Dr. Amit Nagate, Dr. Meenakshi Kalyan to chair the next session.
Good afternoon, everybody. Thyroid diseases, practical challenges are there in our private practice. So I now invite Dr. Uday Phadke to speak on challenges in the management of hypothyroidism.
Thank you. Well, it's a bit of a shame that we still have challenges in management of hypothyroidism. I think this should have been cut and dried by now, but for all those present, I'll go through a few quick points that we need to remember in treating this seemingly simple disorder, but which still there are some problems being left. We see them every day. Some points for you to ponder. What should be the starting dose? Should there be a gradual up titration? What should be the timing of the dose? Is there something called brand fidelity? Are there any dietary changes that we need to follow for thyroid disorders? Now, the treatment for overt hypothyroidism. When we say overt, it means clinical signs, symptoms, low T4, and significantly elevated TSH. We are not talking of TSH of 6 or 7, which is just boundary, and there are lots of discussions about whether we need to treat them. But for such patients, there are several things which determine the dose of thyroxine. Weight is important, and some say the correlation is even better with lean body mass. If you calculate the lean body mass or calculate weight, generally speaking, the dose is dependent on that. Pregnancy status. Normally, for any disease in medicine, we often try to start with a smaller dose of any drug, and we generally up titrate. In pregnancy, we do the opposite. We start with a higher dose and down titrate if necessary. That's to basically achieve rapid control without wasting time. The etiology of hypothyroidism may sometimes matter. If it's a complete loss of thyroid tissue, say like a total thyroidectomy or a radiation-induced destruction of thyroid gland, you require slightly more doses. Some people say that the presence of antithyroid antibodies makes you require slightly more thyroxine than, say, other problems. So the etiology of hypothyroidism matters. The degree of thyrotropin elevation, obviously, the TSH elevation, as I said, matters. Age matters. More elderly the group, a dose will be different. In children, the dose will be different, and I'll show it to you. And of course, the underlying presence of cardiac disease, where one needs to be a little careful in adjusting your doses. So when you're starting treatment, in adult patients with overt hypothyroidism, initial full replacement with a dose of about 1.6 to 1.8 micrograms per kilograms per body weight should be your starting dose. In young, healthy adults otherwise, there is no need to start with 12.5 micrograms and up titrate. You can start with the full dose. This gradual up titration is reserved for elderly patients, for those with critical cardiac disease where you're not sure whether increasing the chronotropic response might cause this patient to tip over into some kind of a anginal crisis. Otherwise, start the dose. Do not do any thyroxine adjustments for at least 6 to 8 weeks. It's a slow-acting tablet. Do the first test after 6 to 8 weeks, and then make a change. This, however, changes slightly in pregnancy, where you start with a larger dose, which can be 2 to 2.5 microgram per kilogram body weight, and you can test them earlier within about a month. In children, the T4 clearance is faster, so double dose is required. In elderly, the clearance is much slower, so less than total dose is required. This is the typical dose that we use in pediatric practice. You can see here that in neonates, we often use something like 10 to 15 micrograms per kilograms per day. And the dose requirement typically starts coming down till you reach adulthood, where the dose typically is about 1.6 to 1.8 microgram per kilogram per day. So in children, especially neonatal hypothyroidism, the idea is to bring about euthyroid status as early as possible to improve brain function or prevent brain damage. So don't start with 12.5 and wait for 2 months and then make it 25. You'll lose the first 2 critical years of brain development. Start with a bigger dose with 15 mics per kg and grade it down as required. The best time of the day to take thyroxine, the usual recommendations are in the morning. It is not compulsory that it should be taken at 3 a.m. and I've known people who wake up at 3, take the dose and then go to sleep because it's early morning. It's all humbug. The idea is to take it when you wake up and not eat anything, maybe for at least half an hour. 1 hour would be even ideal. And why do that? Because food or coffee interferes with absorption of thyroxine. However, you can also take this dose at night, and I'll come back to that a little later. And if you compare this bedtime dose versus breakfast dose, you will see that the TSH is the same in both the groups. So there are several people who may be working in shifts and may find taking it at one particular time to be more convenient. I have no problems there as long as they take the thyroxine either empty stomach in the morning or the last thing before they go to bed. But at the same time every day, it is fine as long as the TSH remains normal. So you don't have to insist that it has to be in the morning. They can do it at night, and both are equally effective. Now what about non-compliance? Non-compliance is pretty much easy to guess, and there are patients who are of course chronically non-compliant, and there you will find that the T4 is low and the TSH is persistently high. And if you take a good drug history, you will find that they have been missing tablets frequently. There are some patients who before coming to us will take some extra doses regularly before they are coming to you. Here you will typically find that the FT4, the T4 level is relatively normal, but the TSH, which takes a much longer time to come down, 6 to 8 weeks after you change the dose, is still high. So compliance is pretty much easy to kind of gather from doing a test and also from getting the drug history. This is a problem that we encounter in some patients, that despite large doses of thyroxine, the TSH is not coming down. Of course, check non-compliance as the first thing. Check drug timing, check the bottle, check the dose, check the expiry, see whether the bottle has gone wrong, because thyroxine is a hygroscopic molecule. If you leave the bottle open for long, it will catch moisture, and a wet tablet is ineffective. So please actually check the tablet to see whether it has been stored incorrectly. After that, check with the relatives whether the patient is taking the tablet, whether he is deliberately kind of playing some truant. And then of course, once all these factors have been ruled out, what you really need to do is find out if there is levothyroxine malabsorption. There are conditions where thyroxine is not absorbed properly. We will come to that. See if there are some conditions in which the thyroxine requirement is actually increased because of excessive turnover, because of some drugs. We'll come to those again later. Sometimes you can do a thyroxine absorption test under your supervision in the clinic to find out if there is a true malabsorption of thyroxine, and then you treat this patient regularly. So how do you do the test? The test is basically done in a myriad number of ways. I'll just give you a very simple example. You call the patient and either give him 600 micrograms of thyroxine, all right? And you watch him every hour and test free T4 level. By about the third hour, if you find that the FT4 levels are going up by more than 0.5 nanograms per deciliter, it indicates that thyroxine is being absorbed. It is not actually thyroid malabsorption. Then you need to do a lot of things to make sure that this patient is taking the tablet. You can entrust it to a family member. You can call him to your clinic and give him the whole week's dose by your hand once a week and make him sit there for 1 hour to make sure that he doesn't throw up or anything, and then check the TSH in again 3 or 4 weeks. The follow-up, and this is a question which people keep asking us, do I need to take the drug lifelong? The easy answer is yes, if the drug is not required lifelong. I mean, thyroid is an autoimmune disorder in most patients and self-remissions are known. But if that happens, the TSH will start going down on whatever dose you're giving, and then you can reduce the dose. Otherwise, thyroxine is not a short-term proposition. It's done. Do we require to reduce the dose after the TSH has gone down? No. This is a replacement therapy. So if your TSH is normal on whatever dose you're giving today, if the TSH is normal, it indicates that you need to continue the same dose. That is important. Don't try and reduce dose because the TSH is normal. The TSH is normal because you're giving the correct dose. It's only in post-delivery where the requirements of thyroxine have gone up during pregnancy, you can actually reduce the dose by about 20 to 30% post-delivery. The frequency of testing, the first test after starting therapy should be at least after about 6 to 8 weeks. Maybe you can do another test after 6 months and one again after 6 months. And if you find that the TSH is now well stabilized, you genuinely call them yearly. You do not need to test TSH every month or 2 months or 3 months. It's pointless. So every year is fine. And what to do? If the TSH is between 0.5 to 5, continue the same dose. If it is more than 5, you need a small increment. Always remember, the increments have to be small. So if it's on 100, don't make it 200. Make it 112.5, 125. Similarly, if the TSH is going low, reduce the dose by 12.5. I mean a small decrement. Don't stop, don't halve the dose. Otherwise, you are producing lots of problems. As far as brand fidelity goes, different companies manufacture thyroxine in different manners. Their storages are different. So if your patient is comfortable on some brand, and if the thyroid at the TSH test is coming normal, by and large, please do continue to follow the same brand, the same dose. This is not just logic and common sense. This has been put to test in certain studies in America, and they have found that changing brands actually changes TSH. So it's simpler and safer and logical to continue the same dose or same brand of thyroxine, whichever it might be. Antithyroid antibodies will be spoken at various times during this meeting, but the real value of doing antithyroid antibodies, well, in one, it tells you what the cause of hypothyroidism is, but in most cases it is autoimmune, but it also correlates with development of future hypothyroidism in patients with subclinical hypo. If you're interested in knowing that, you may do it. Some people say that those with positive thyroid antibodies do require a slightly higher dose of thyroxine. It's not 100% sure. And the chance of developing hypothyroidism with antibody positivity is about double than with negative antibodies. The TSH receptor antibodies are not for hypothyroidism, they're used for Graves, I'm skipping that. What do we do with subclinical hypo? And I don't know if you were in the other hall, Karthik spoke about subclinical hypo. It was an excellent presentation. In a nutshell, if your TSH is more than 10, I'm just going to show you this guideline, it's not very clear on this. If your TSH is more than 10, by and large, treatment is always necessary. If it is less than 10, individualize it. If there is a chance, there are multiple factors for developing metabolic syndrome or some coronary artery disease or cerebrovascular disease, treating subclinical hypo below 10 is beneficial. If it's absolutely there are no other risk factors, you may choose to just carefully observe. All this hype about starting treatment in large doses just because the TSH has come out with a flag from the lab is to be completely abhorred. Especially after the age of 75, treatment of hypothyroidism, in fact, is to be undertaken very, very, very judiciously. In fact, if you start thyroxine for subclinical hypothyroidism above the age of 70, in fact, it might be deleterious to your patient. It may increase mortality, and we have data on that. So be very careful. People, elderly, coming to us saying that I'm feeling tired, I'm feeling fatigued, you do a TSH and it is 7. You say, okay, this is your diagnosis. Start thyroxine. No, it will harm them. Remember last couple of slides that there are, when you interpret your thyroid hormone studies or tests, be aware that biotin is commonly ingested by patients through a variety of over-the-counter vitamin preparations. And you will be amazed to what kinds of interference in assays biotin does. You will get weird readings, high T4, low T3, high TSH, low TSH. Any combinations can come up with biotin. And the problem is that you can't even test that biotin separately because it's rapidly washed out of the circulation. So some people are developing assays which are free of biotin interference, but we still don't have them. So please, if you're getting weird results, talk to the patients to find out if they are taking biotin. And some drug interactions, so proton pump inhibitors, antacids interfere. Iron and calcium interferes with absorption. Carbamazepine, phenytoin, the last 1 minute maybe, if I'm allowed to continue. Carbamazepine, phenytoin, rifampicin, and oral contraceptives rapidly turn over thyroxine. So if you're using antitubercular drugs, you may sometimes require larger doses of thyroxine. Amiodarone is one important drug that you need to remember, pretty commonly used for arrhythmias. It can play both hypothyroidism and thyrotoxicosis. And the last is diet. A lot of people will keep asking you about, everyone will say, the kobi khauka, flour khauka. It's all these goitrogens have very, 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 very minimal impact. And that is also if you consume large quantities of raw vegetables in people who have severe iodine deficiency and borderline hypothyroidism will have a slight exacerbation of TSH. The way we normally eat, there is absolutely no need to follow any kinds of diet for hypothyroidism alone. Thank you very much for listening.
Thank you very much. We'll take up the question and answer session at the end.